All right, let's get started. Today, we're diving into something that's, frankly, pretty high stakes for any trainee: eye emergencies. These are the conditions where a fast, correct diagnosis can literally be the difference between a patient seeing and a patient going blind. So let's jump right in.
So picture this. A patient walks in with a serious eye problem. The pressure is on, you've got to be sharp, your differential has to be on point, and you need to know exactly when to call for help. This whole guide is designed to get you ready for that very moment. So here's our game plan. We're going to build a solid framework, starting with which conditions are true emergencies. Then we'll hit ocular trauma, tackle the super common but tricky red eye, unpack those scary, silent causes of vision loss, do a deep dive on acute glaucoma, and then wrap it all up with a concrete action plan you can take with you on your next shift. Okay, let's get into it. The very first, and you could say most important step, is knowing which diagnoses just cannot wait. These are the ones where you need to get an ophthalmology consult, and you need to do it right now. Look, this isn't just a random list. This is your high alert checklist. We're talking about things like acute angle closure glaucoma, chemical splashes, nasty infections like orbital cellulitis and keratitis, vascular catastrophes like a retinal artery occlusion, and of course structural problems like a retinal detachment. Every single one of these means you stop what you're doing, you pick up the phone, and you get an ophthalmologist involved immediately. All right, next up, trauma. When it comes to an eye injury, your mission is simple, but it is absolutely critical. You have to assess the damage and then protect the globe from any further harm. Okay, take a good look at this. You see that clear layering of blood in the front of the eye? That's called a hypha, and it is a major, major red flag. It screams significant injury and could mean the globe itself is ruptured. Even if it's just a tiny amount of blood, that patient needs a slit lamp exam. This is not a watch and wait situation. So, if you suspect a globe injury, you need to know exactly what to do, and maybe more importantly, what not to do. First, always check their vision. Then, look for those telltale signs like a weirdly shaped pupil or that hyphema we just saw. But, and this is a big one, whatever you do, do not check the intraocular pressure. You could literally squeeze the contents of the eye out. Instead, you're going to place a rigid shield over the eye, not a patch, a shield, and make that call to ophthalmology right away. All right, let's move on to probably the most common eye complaint you will ever see: the red eye. The real challenge here is separating the harmless stuff, like a simple pink eye, from the really scary diseases that can hide behind that same red appearance. Let's put two of these lookalikes side by side: episcleritis and scleritis. On the one hand, you have episcleritis, which is more of a superficial irritation, and vision is usually totally fine. But on the other hand, you have scleritis. We're talking severe, deep, boring pain, often with vision loss. And here's the kicker. Over half the time, it's tied to a systemic disease like rheumatoid arthritis. This one is a true vision-threatening emergency. And you can really see the difference here, right? On the left, with episcleritis, you see those superficial, bright red vessels. But look at the scleritis on the right. That color is deeper. It's almost a purplish, violaceous hue. That tells you the information is in that deep scleral layer. That color difference is a huge visual clue. Now, let's set a baseline with good old bacterial conjunctivitis. Pink eye. Usually, it's just some irritation, a little crusting in the morning. And get this, about 65% of cases actually get better all on their own in a few days, even without antibiotics. But you can't get complacent. Because if you see this, your entire approach has to change. This massive, just incredible amount of purulent discharge is the classic sign of hyperacute bacterial conjunctivitis. We're usually talking about Neisseria gonorrhea. This is not your average pink eye. This bug can perforate the cornea and cause blindness fast. This is an absolute emergency. And here's another imposter. A patient, especially one who wears contact lenses, comes in with a painful red eye and blurry vision. If you look closely and see a corneal opacity, like that little white spot there, your brain should be screaming keratitis. That's an inflammation of the cornea itself. And yep, you guessed it, it's another can't-miss diagnosis that needs an immediate consult. Okay, let's shift gears to a category that's honestly a little sneaky. These are the emergencies where the lack of pain can actually fool you and the patient into thinking things aren't that bad, but the threat to their vision, it's just as severe. So you really gotta fight that little voice in your head that says, no pain, no problem. Because in ophthalmology, a lot of the time, the exact opposite is true. Sudden, painless vision loss should set off the biggest alarm bells in your head.
It's a sign of a crisis happening in the back of the eye. And this is what's going on back there. On the left, you're looking at a retinal detachment. The retina is literally peeling off the back wall of the eye. Now look to the right. Whoa, that's a central retinal vein occlusion. We call it a blood and thunder fundus for a reason. You can see all those hemorrhages. Both of these are silent, and both are completely devastating.
You have to listen, really listen, to your patient's story. If they say they're seeing flashes of light and new floaters, you should immediately think retinal detachment. Same if they describe a curtain falling over their vision. If the story is a sudden, total blackout, think central retinal artery occlusion. And if it's more of a painless, blurry situation, think central retinal vein occlusion. These phrases are classic textbook clues. Now for our final deep dive, glaucoma. But let's be really specific. We're focusing on the acute attack, which is a whole different animal from the slow, chronic glaucoma that many people are more familiar with. So let's be crystal clear here. The slow, creeping vision loss of primary open-angle glaucoma is a serious chronic disease, no doubt. But what we're talking about right now is acute angle closure glaucoma. This is a sudden, catastrophic spike in eye pressure that needs to be treated within hours, if not minutes, to save vision. And luckily for us, it presents with a pretty classic triad of symptoms that you can latch onto. Number 1, severe, deep, awful eye pain. Number 2, they feel systemically sick, so think headache, nausea, even vomiting from the pain. And number 3, that classic visual symptom of seeing halos or rainbows around lights. You hear that story, your brain should immediately go to acute glaucoma. Okay, that was a ton of information. So let's pull it all together into a final action plan, something you can actually use to structure your thinking when you're under pressure and things get hectic. Think of this table as your mental cheat sheet. Let's run through it. Red flag is severe pain with a vision change. You're thinking scleritis, keratitis, or acute glaucoma. Action, urgent ophtho consult. Red flag is sudden, painless vision loss. Think retinal detachment or an occlusion. Action, urgent ophtho consult. Suspected globe rupture. Action, shield the eye and get that urgent consult. Copious purulent discharge. Think hyperacute conjunctivitis and call. Finally, if the eye is bulging out and it hurts to move, that's called proptosis. Think orbital cellulitis. You see the pattern here, right? For almost all of these, the immediate action is the same. Get an urgent ophthalmology consult. Look, if you walk away with nothing else, please remember this framework. For any patient with an eye complaint, your initial questions should hit these 5 cardinal features. Was there trauma? Is there any discharge? Is there pain? Are bright lights bothering you? And the big one, has your vision changed at all? And that really brings us back to the core of what you're doing as a trainee. It's all about asking the right questions to uncover those red flags quickly and efficiently. So after everything we've just covered, what's the first question you're going to ask?